Welcome everyone. Today is the first of what will be a series of 4 guest lectures throughout the semester. There will be 2 guest lectures starting the week from today, and then there'll be another one towards the end of the semester. And what Pete and I decided to do is to bring in people who know a lot more than us about some area of expertise. In today's instance, it's going to be about cardiovascular medicine, in particular about how to use imaging and machine learning on images in that context. And for today's lecture, we're very excited to have Professor Rahul Deo to speak. Rahul's name kept on showing up as I did research over the last couple of years. First, my group was starting to get interested in echocardiography, and we said, here's an interesting paper to read on it. We read it, and then we read another paper on doing subtyping of preserved ejection fraction as a type of heart failure. And we read it. I wasn't really paying attention to the names on the papers. And then suddenly someone told me, there's this guy moving to Boston next month who's doing a lot of interesting work and is interested in machine learning. You should go meet him. And of course I meet him, and then I tell him about these papers I read, and he said, I wrote all of those papers. He was the senior author on them. So Rahul's been around for a while. He is already somewhat senior in this field. He started out doing his medical school training at Cornell Medical School in New York City, at the same time as doing his PhD at Rockefeller University. And then he spent the first large chunk after his postdoctoral training up here in Boston at Harvard Medical School. He spent a large chunk of his career as faculty at UCSF in California, and just moved back this past year to take a position as the chief data scientist, is that right? Mm-hmm. For the One Brave Idea project, which is a very large initiative joint between MIT and Brigham and Women's Hospital to study cardiovascular medicine. He'll tell you more maybe. Mm-hmm. And Rahul's research has really gone the full spectrum, but the type of things you'll hear about today is actually not what he's been doing most of his career, amazingly so. Most of his career has been thinking more about genotype and how to really bridge that genotype-phenotype branch. But I asked him specifically to talk about imaging, so that's what he'll be focusing on today's lecture. And without further ado, thank you, Rahul, for coming here.
Thanks so much, David. So I'm used to lecturing the clinical audiences, so you guys are by far the most technical audience. So please spare me a little bit. But I actually want to encourage interruptions, questions. This is a very opinionated lecture, so that if anybody has sort of any questions, reservations, please bring them up during the lecture. Don't wait till the end. And in part, it's opinionated because I feel sort of passionately that the stuff we're doing needs to make its way into practice. It's not by itself purely academically interesting. Many of the things we're doing are kind of already picking up what everybody else here is already doing, but at the same time, so it's okay from that standpoint, but it really has to make its way, and that means that we have to have some mature understanding of what makes its way into practice, where the resistance will be. So the lecture will be kind of peppered throughout with some kind of opinions and comments in that, and hopefully that will be useful. So just a quick outline. Just going to introduce cardiac structure and function, which is probably not part of the sort of the regular undergraduate and graduate training here at MIT. Talk a little bit about what the major sort of cardiac diagnostics are and how they're used. And all of this is really to help guide the sort of the thought and the decision making about how we would ever automate and bring this into sort of how to bring machine learning, artificial intelligence into actual clinical practice. Because you need to give enough background so that you realize what the sort of the challenges are. And then the question probably everybody has is, where's the data? How would one get access to some of this stuff to be able to potentially do work in this area? And then I'm going to sort of venture a little bit into computer vision and just talk about some of the topics that at least I've been thinking about that are relevant to what we're doing. And then talk about some of this work around an automated pipeline for echocardiogram, not as by any means a gold standard, but really just as sort of an initial foray into trying to make a dent into this. And then thinking a little bit about what lessons, David mentioned that you talked about electrocardiograms last week or last class, and so a little bit of some of the ideas from there and how they would lend themselves to insights about future types of approaches with automated interpretation. And then my background is actually more in biology, so I'm going to kind of come back and say, well, okay, enough with all this imaging stuff. What about the biology? How can we make some insights there? Okay, so every time people try to get funding for coronary heart disease, they try to talk up just how important it is. So this is still, we have some battles with the oncology people, but this is still the leading cause of death in the world. And then people are like, oh, you're just emphasizing the developed world. There's lots of communicable diseases that matter much more. So, but even if you look at those and you sort of look at the bottom here, if this is sort of all causes of death age adjusted, cardiovascular disease is still sort of number one amongst that. So certainly it remains important, and sort of increasingly so in some of the developing world also. So it's important to think a little bit about what the heart does, because this is going to guide at least the way that diseases have been classified. So the main thing the heart does is a pump, and it delivers oxygenated blood throughout the circulatory system to all the tissues that need it, the brain, the kidneys, the muscles. And oxygen, of course, is required for ATP production. So it's a pretty impressive organ. Pumps about 5 liters of blood a minute, and with exercise, that can go up 5 to 7-fold or so with sort of conditioned athletes, not me, but other people can kind of ramp that up substantially. And we have this sort of need to keep a very, very regular beat. So if you pause for about 3 seconds, you are likely to get lightheaded or pass out. So you have to maintain a sort of this rhythmic beating of your heart, and you can kind of compute what that would be, and somewhere around 2 billion beats in a typical lifetime. So I'm going to show a lot of pictures and videos throughout this, so it's probably worthwhile just to take a pause a little bit and talk about what the anatomy of the heart is. So the heart is sort of sits like this, so the pointy part is kind of sitting out to the side like that. And so I'm going to just sort of describe the flow of blood. So the blood comes in something called the inferior vena cava, or the superior vena cava. This is draining from the brain, this is draining from the lower body, and then enters into a chamber called the right atrium. It moves through something called the tricuspid valve into what's called the right ventricle. So the right ventricle has got some muscle to it. It pumps into the lungs. There the blood picks up oxygen, so that's why it's sort of shown as being red here. The oxygenated blood comes through the left atrium and then into the left ventricle through something called the mitral valve. We'll show you some pictures of the mitral valve later on. And then the left ventricle, which is the big sort of workhorse of the heart, pumps blood through the rest of the body through a structure called the aorta. So in through the right heart, through the lungs, through the left heart, to the rest of the body. And then shown here in yellow is the conduction system. So you guys got a little bit of a conversation last class on the electrical system. So the sinoatrial node is up here in the right atrium, and then conduction sort of goes through. So the P wave on an EKG represents the conduction through there. You get through the AV node where there's a delay, which is the PR interval, and then you get spreading through the ventricles, which is the QRS complex, and then repolarization is the T wave. So that's sort of the electrical system, and of course these things have to kind of work intimately together. Every every single basic kind of cardiac physiology will show this diagram called the Wigner's diagram, which really just shows the sort of the interconnectedness of the electrical system. So there's the EKG up there. These are the heart sounds that a provider would listen to with the stethoscope. And this is capturing the flow of sort of the changes in pressure in the heart and in the aorta. So heart fills during a period of time called diastole. The mitral valve closes, the ventricle contracts, the pressure increases. This is a period of time called systole. Eventually, something called the aortic valve pops open, blood goes through the rest of the body, heart finally starts to relax, atrioventricular valve closes, then you fill again. So this happens again and again and again in a cyclical way, and you have this kind of combination of electrical and mechanical properties. Okay, so I have some pictures here. These are all MRIs. I'm going to talk about echocardiography, which is sort of these very ugly, grainy things that I unfortunately have to work with. MRIs are beautiful, but very expensive. So there's a reason for that. So this is something called the long axis view of the heart. So this is the thick-walled left ventricle there. This is the left atrium there, and you can see sort of this beautiful turbulent flow of blood in there, and it's flowing from the atrium to the ventricle. This is another patient. It's called the short axis view. There's the left ventricle and the right ventricle there. So we're kind of looking at it somewhat obliquely. And then this is another view called it's a little bit dull there, I'm sorry. We can brighten it a little bit. This is sort of what's called the four-chamber view. So you can see the left ventricle and right ventricle here. So the reason for these different views is ultimately that people have measures of function and measures of disease that go along with these specific views. So you're going to see them kind of coming back again and again. Okay, so the way that physicians like to organize disease definitions really around some of these same kind of functions. So failures of the heart to pump properly causes a disease called heart failure. And this shows up in terms of being out of breath, having fluid build up in the belly and in the legs, and this is treated with medications. Sometimes you can have some artificial devices to help the heart pump, and ultimately you could even have a transplant depending on how severe it is. So that's the pump. Blood supply to the heart ultimately can also be blocked, and that causes a disease called coronary artery disease. If blood is completely blocked, you can get something called a heart attack or myocardial infarction. That's chest pain, sometimes shortness of breath, and we open up those blocked vessels by angioplasty, stick a stent in there, or bypass them altogether. And then the flow of the flow of blood has to be one way. So abnormalities of flow of the blood through valves is valvular disease, and so you can have either too tight valves, so that's called stenosis, or you can have leaky valves, that's called regurgitation. That shows up as lightheadedness, shortness of breath, fainting, and then you've got to fix those valves. And finally, there's abnormalities of rhythm, so something like atrial fibrillation, which is a quivering of the atrium. So too slow heartbeats, ventricular tachycardia, can present as palpitations, fainting, or even sudden death. And you can stick a pacemaker in there, or a defibrillator in there, or try to burn off the arrhythmia. Okay, so this is like the very physiology-centric view, but the truth is that the heart has a whole lot of cells. So there's a lot more biology there than simply just thinking about the kind of the pumping and the electrical function. Only 30% of the cells or so are these cardiomyocytes. So these are the cells that are involved in contraction. These are the cells that are excitable, but that's only 30% of the cells. There's endothelials in the cell, there's fibroblasts, there's a bunch of blood cells in there too, certainly a lot of red blood cells in there too. So you have lots of other things. So we're going to come back to here a little bit when talking about how should we be thinking about disease. The sort of historic way is to think about pumping and electrical activation, but really there's maybe a little bit more complexity here that needs to be addressed. Okay, so there's a lot of different. So cardiology is very imaging centric, and as a result, it's very expensive because imaging costs a lot of money to do. And so I have dollar signs here reflecting the sorts of different tests we do. So you saw the cheapest one last week, the electrocardiogram, so $1 sign. And that's used for, that's lots of utility. For example, one could diagnose an acute heart attack with that. Echocardiography, which involves sound waves, is ultimately more used for quantifying structure and function, can pick up heart failure, valvular disease, high blood pressure in the lungs, so that's another modality. MRI, which is just not used all that much in this country, is very expensive, but does largely the same things. And you can imagine, even though it's beautiful, people have not had an easy time and able to justify why it's any better than this slightly cheaper modality. And then you have angiography, which can either be by CAT scan or by X-ray, and that visualizes the flow of blood through the heart and looks for blockages, which are going to be stented, ballooned up and stented. And then you have these kind of non-invasive technologies like PET and SPECT that use radionuclides like technetium, rubidium, and they look for abnormalities in blood flow to detect whether non-invasively there's some patch of the heart that isn't getting enough blood. If you get one of these and it's abnormal, often you go over there. You can take a trip to the movies, as my old teachers used to say, and then you may find yourself with an angioplasty or a stent or a bypass. So one of the sort of sad things about cardiology is we don't define our diseases by biology. We define our diseases often related to whether the anatomy or the physiology is abnormal or normal, usually based on some of these images or some of these numbers. Okay, so we have to make decisions, and we often use these very same things too to be able to make some decisions. So we have to decide whether we want to put a defibrillator, and to do so, you often need to get an echocardiogram to look at the pumping function of the heart. If you want to decide on whether somebody needs an angioplasty, you have to get an angiogram. If you want to decide to get a valve replacement, you need an echo. But some of these other ones actually don't involve any imaging, and this is sort of one of the challenges that I'm going to talk about, is that all of the sort of the future, if you can imagine building brand new risk models, new classification models, you're stuck with the data that's out there. And the data that's out there has ultimately been collected because somebody feels like it's worth paying for it already. So if you want to build a brand new risk model for who's going to have a myocardial infarction, you're probably not going to have any echocardiograms to be able to use for that, because nobody is going to have paid for that to be collected in the first place. So this is a problem. To be able to innovate, I'm going to keep on coming back to that, because I think you're going to be shocked by the small sample sizes that we face in some of these things. And part of it is because if you just want to piggyback on what insurers are going to be willing to pay for to get your data, you're going to be stuck with only being able to work off the stuff we already know something about. So much of my work has been really trying to think about how we can change that. Okay. So just a little bit more, and then we can get into sort of a little bit more meat. So the sort of the universal standard for how imaging data is stored is something called DICOM, so Digital Imaging and Communication Standard. And really, at the end of the day, there's some compressed data for the images. There's a DICOM header, which I'll show you in a moment. There's lots of nice Python libraries that are available to be able to work with this data, and there's a free viewer you can use too. Okay, so where do I get access to this? So this has actually been an incredible pain. So hospitals are set up to be clinical operations. They're not set up to make it easy for you to get gobs of data for being able to do machine learning. It's just not really there. And so sometimes you have some of these kind of data archives that store this data, but there's lots of reasons for why people make that difficult. And one of them is because often images have these burned-in pixels with identifiable information. So you'll have a patient's name emblazoned in the image. You'll have date of birth. You'll have kind of other attributes. So you're stuck with that. And not only is it a problem that they're there, the vendors don't make it easy to be able to get rid of that information. So you actually have a problem that they don't really make it easy to either download in bulk or de-identify this. And part of the reason is because then it would make it easy for you to switch vendors and have somebody else take over. So they make it a little bit hard for you. Once it's in there, it's hard for you to get it out. And people are selling their data. That's certainly happening too. So there's a little bit of kind of attempts to try to control things that way. And many of the labels you want are stored separately. So you want to know what the diseases of these people. So you have the raw imaging data, but all the clinical stuff is somewhere else. So you have to sometimes link that, and so you need to get access there. And so just to give you a little bit of an idea of scale, so we're about to get all the ECGs from Brigham and Women's, which is about 30 million stored kind of historically. And this is all related to cost. So if positron emission tomography, you can get about 8,000 or so, and we're one of the busiest centers for that. Echocardiograms are in the 300,000 to 500,000 range as archived, so that gets a little bit more interesting. Okay, so what a DICOM header looks like, you have some sort of identifiers, and then you have some information there, attributes of the images, patient name, date of birth, frame rate, these kind of things are there, and there's some variability, so it's never quite easy. Okay. So these different modalities have some different benefits to them, and which is why they're used for one disease or the other. And so one of the real headaches is that the heart moves. So the chest wall moves because we breathe, and the heart moves too. So you have to image something that has enough temporal frequency that you're sort of not overwhelmed by the basic movement of the heart itself. And so some of these things aren't great. So SPECT or PET acquire their images, which are radioactive counts, over minutes. So that's certainly a problem when it comes to something that's moving like that, and if you want to have high resolution. So you typically you have very poor spatial resolution for something that ultimately doesn't deal well with the moving aspect. So coronary angiography has very, very fast frame rates. So that's X-ray, and that's sort of very fast. Echocardiography can be quite fast. MRI and CT are not quite as good, and so there's some degradation of the image. As a result, people do something called gating, where they'll take the electrocardiogram, the ECG, and try to line up different portions of different heartbeats and say, well, we'll take this image from here, line it up with this one from there, this one from there. I'm going to talk a little bit about that, about registration, but ultimately that's a problem that people have to deal with. So it's a computer vision problem of interest. Okay, preamble's almost done. Okay, so why do we even imagine any of this stuff is going to be useful? So it turns out that the practice of interpreting involves a lot of manual measurements. So people like me and people who should have trained for way too long find themselves getting little rulers and measuring various things. So for example, this is a narrowing of an artery. So you could take a little bit of calipers and measure across that and compare it to here and say, this is 80% narrowed. You could measure the area of this chamber, the left ventricle, and you can measure what its area is, and you can say, its peak area is this, its minimum area is this, therefore it's contracting a certain amount. So we do those things. We measure those things by hand. And the other thing we do is we actually diagnose things just by looking at them. So this is a disease called cardiac amyloid. characterized by some thickening. I'll show you a little bit more about that, and some speckling here. So people do look and say, this is what it is. So there's a kind of a classification problem that comes either at the image or video level. So we'll talk about whether this is even worth doing. But yes?
Is this with software, or do you literally take a ruler and measure this?
So the software involves clicking at one point, stretching something, and clicking at another point. So it's a little better than pulling the ruler out of your back pocket, but not that much better. OK, so we're going to talk about sort of 3 little areas. And again, this is not, I got involved in this really in the last 2 years or so. It's nice of David to ask me to speak here, but I think there are probably people in this room who have a lot more experience in this space. But the areas that have been relevant to what we've been doing has been image classification, and then semantic segmentation. So image classification being assigning a label to an image, very great. Semantic segmentation, assigning each pixel to a class label. And we haven't done anything around the image registration, though there are some interesting problems that I'm thinking about there. And that's really mapping different sets of images onto one coordinate system. OK, so seems obvious that image classification would be something that you would imagine a physician does, and so maybe we can mimic that. Seems like a reasonable thing that happens. And so lots of things that radiologists, people who interpret images, do involved in terms of recognition, and they're really fast. So it takes them a couple of minutes to often do things like detect if there's lung cancer, detect if somebody has a pneumonia, detect if there's breast cancer in a mammogram, tell if there's fluid in the heart. Even less than that, 1 minute often, 30 seconds. They can sort of very, very fast. So you can imagine, the sort of the wave of excitement around image classification was really kind of post-ImageNet. So maybe about 3 years, 4 years or so ago. We're always a little slow in medicine, so a little bit behind other fields. And the places that they went were the places where there are huge data sets already and where there's simple recognition tasks. So chest x-rays and mammograms were both places that they had a lot of attention. And other places have been slowed down by just how hard it is to get data. So if you can't get a big enough data set, then you're not going to be able to do much. OK. So David mentioned you guys already covered very nicely. And this is probably kind of old hat. But I would say that prior to convolutional neural networks, nothing was happening in the image classification space in medicine. It was just not. People weren't even thinking that it was even worth doing. Now there's a lot of interest. And so I have many different companies coming and sort of asking for help with some of these things. And so it is now a very attractive sort of thing in terms of thinking. And I think people haven't thought out all that well how we're going to use that. So for example, if it takes a radiologist 1 minute to 2 minutes to read something, how much benefit are you going to get to automate it? And the real problem is you can't take that radiologist away. They're still there because they're the ones who are on the hook, and they're going to get sued, and it's among the most sued profession in medicine. So there's lots of people who can read an X-ray. You don't need to have all that training. But if you're the one who's going to be sued, it ends up being that there really isn't any task shifting in medicine. There isn't that kind of, I'm going to let such and such take on 99% and just tell me when there's a problem. It just doesn't happen because they ultimately don't feel comfortable passing that on. So that's something to think about. So you have a task that's relatively easy for a very, very expensive and skilled person to do, and they refuse to give it up. OK, so that's a problem. But you can imagine there are some scenarios, and we'll talk more about this, as to where that could be. So let's say it's overnight, the radiologist is sleeping comfortably at home, and you have a bunch of studies being done in the emergency room, and you want to figure out, OK, which one should we call them about? So you can imagine there could be triage. Because the status quo would be, we'll take them one by one. Maybe you could imagine sifting through them quickly and then reprioritizing them. They'll still be looked at by, every single one will still be looked at. It's just the order may change. So that's an example. And you could imagine there could be separate, someone else could read at the same time. And we'll come back to this in terms of whether or not you could have 2 streams and whether or not that is a scenario that would make some sense. And maybe in resource-poor settings where we're not teaming with radiologists, maybe that makes sense too. So we'll come back to that too. OK, so here's another problem. So almost everything in medicine requires some element of confirmation of a visual finding. And some of the reasons are very simple. So let's say you want to talk about there being a tumor. So if you're going to ask a surgeon to biopsy it, you better tell them where it is. It's not enough to just say this image has a tumor somewhere in it. So there's some element of that you're going to need to be able a little bit more detailed than simply making a classification at the level of an image. But I would say beyond that. So let's say I'm going to try to get one of my patients to go for valve surgery. I'll sit with them bring up their echo, sit side by side with them, and point them to where it is, bring up a normal one and compare, because I want them to be involved in the decision. I want them to sort of feel like they're not just and they have to trust me. At the end of the day, they don't even know that I'm showing them. I mean, I'll show them their name, but ultimately, there is some element of trust. They're not able to do this, but at the same time, there is sort of this sense of shared decision making. You're trying to communicate to somebody whose life is really, at risk here, that this is why we're doing this decision. So the more you could imagine that there's obscuring, the more difficult it is to make that case. So medicine is sort of this, I found this review by Bin Yu from Berkeley, just came out. And it sort of talks about this kind of this tension between predictive accuracy and descriptive accuracy. So this is sort of the typical thing we think about that matters, and there's lots of people who've written about this sort of thing. And medicine is tough in that it's very demanding in this space here, and it's sort of almost inflexible in this space here. So it's sort of a tough nut to crack in terms of being able to make some progress. And so we'll talk more about when that's likely to happen. Okay, so this again may be something that's very familiar too. So we had this problem in terms of some of the disease detection models, and I didn't find this all that satisfying in terms of being able to successfully localize. So just digging through the literature, it looks like this sort of idea of being able to sort of explain what part of the image is driving a certain classification. That field is sort of modestly old. Maybe it goes back before that. But ultimately, there's sort of two broad ways. You can sort of imagine finding an exemplar image that maximally activates the class score. Or you can take a given image and say what aspect of it is sort of driving the classification. And so in this paper here, sort of did both those things. They either went through and kind of optimized this, starting from an average of all the training data, they sort of optimized the intensities until they maximized the score for a given class. So that's what's shown here. And then another way to do it is that, in some sense, you could take a kind of a derivative of the score function relative to the intensities of all the pixels and come up with something like this. But you can imagine if you showed this to a patient, they wouldn't be very satisfied. So it's very difficult to make a case that this is super useful. But it seems like this field has progressed somewhat. And I haven't tried this out. This is a paper by Max Welling and company out by a couple of years, and maybe you guys have some familiar with this. But this ultimately is a little bit of a different approach in the sense that they take sort of patches, the sort of purple-like patch here, and they compare the sort of the final score or class label relative to what it, so taking the intensity here and replacing it by a conditional result sampling from the periphery and just comparing those two things and seeing whether or not you either get activation, which is sort of the red here, this is the way that they did the sort of conditional sampling, and then blue would be sort of the sort of negative contributors. And there you can imagine there's a little bit more distinction here, and then something a little bit more on the medical side. This is a brain MRI, and so depending on this sort of patch size, you get sort of a different degree of sort of resolution to localizing some areas of the image that are relevant. So this is something that we're going to expect a lot of demands from the medical field in terms of being able to show this. And at least our initial forays weren't very satisfying doing this with what we were doing, but maybe these algorithms have gotten better. OK, so next thing that matters. OK, so this is what people do. So I spent, I did my cardiology fellowship at MGH, and I just traced circles. That's what I did. I just traced circles, and I stretched a ruler across, and then fed that in. At least the program computed the volumes for me, the areas and volumes. But otherwise, you have to do this yourself. So this is like a task that's done. And sometimes you may have to sort of, here's sort of an example of volumes being computed by tracing these sorts of things. And much of radiology reports just involve doing that. So this seems like a very obvious task we should be able to improve on. So medicine tends to be not the most creative in terms of trying a bunch of different architectures. So if you look at the papers, they sort of all jump on the UNet as being the sort of the favorite sort of architecture for semantic segmentation. So maybe familiar to people here, really just it kind of captures this sort of encoding or contracting layer where you're downsampling, and then there's sort of a symmetric upsampling that takes place. And then ultimately, there's these sort of skip connections where you take an image and then you concatenate it with this sort of upsampled layer, and this helps get a little bit more localization. So we use this for our paper, and we'll talk about this a little bit, and it's very popular within the medical literature. One of the things that was quite annoying is that what you would find for some of the images, you'd find, let's say, a ventricle, you'd find this nicely segmented area, and then you'd find this little satellite ventricle that the image would just pick. So you'd get this, the problem is that this sort of pixel level classification tends to be a problem, and a human would never make that mistake, but that tends to be something that sounds like it is common in the, this is a kind of a common tension, is that this sort of focusing on relatively limited scales ends up being problematic when it comes to kind of picking up global, kind of the global architecture. And so there's lots of different solutions, it looks like, in the literature. I just highlighted some of these from a paper that was published from Google a little while ago. One of the things that's captured is these sort of ideas of dilated convolutions, and so that you imagine you have sort of convolutions built on convolutions, and so ultimately you have a much bigger receptive field for this layer, though you haven't really increased the number of parameters that you have to learn. So there's some, it seems like there's lots. This is not just a problem for us, but a problem for many people in this field. So we need to be a little bit more adventurous in terms of trying some of these other methods. We did try a little bit of that and didn't find huge gains, but I think ultimately there still needs to be a little bit more work there. OK, so the last thing I'm going to talk about before getting into my work is really this idea of image registration. So I talked about how there are sometimes some techniques that have limitations either in terms of spatial resolution or temporal resolution. So this is a PET scan here, this sort of reddish glow here. And in the background, we have a CAT scan of the heart. And so clearly, this is a poorly registered image where you have the PET scan kind of floating out here when it really should be lined up here. And so you have something that's registered better there. I also mentioned this problem about gating. So ultimately, if you have an image taken from different parts of different cardiac cycles, you're going to have to align them in some way. So this is it sounds like a very mature problem in the computer vision world. We haven't done anything in this space, but ultimately it has sort of been around for decades. Thought I would just at least touch upon it. So this is sort of the old school way, and then now people are starting to use conditional variational autoencoders to be able to learn geometric transformations. This is the Siemens group out in Princeton that has this paper. Again, nothing I'm going to focus on, just wanted to bring it up as being an area that remains of interest. OK, so I think we're doing OK. Wait, you said 4. OK, 3:55. OK. All right, and please interrupt, OK? Don't, I'm hoping that I'm not talking too fast. OK, so I'm going to talk about, as David said, this was not my field, but increasingly there is some interest in terms of getting involved in part because of my frustrations with clinical medicine. So this is one of my frustrations with clinical medicine. So cardiology has not really changed, and one of the things it fails at miserably is picking up early onset disease. So here's a kind of the typical profile, a little facetious. So people like me in our early 40s start to already have some problems with some of these numbers. So I like to joke that since I came back to the Harvard system from California, my blood pressure has gone up 10 points, which is true, unfortunately. But so these changes already start to happen, and nobody does anything about it. So you can go to your doctor. And you're also saying, no, I don't want to be on any medicines. They're like, no, you shouldn't be on any medicine. So you kind of hem and haw, and a decade goes by, 15 years go by, and then finally you're like, OK, well, it looks like at least my coworker's on some medicine, so maybe I'll be willing to do that. And so there we have lots of stuff you can be treated with, but it's often very difficult, and you see this at the doctor level too. Yes?
Just for the optimal values, how much personal deviation is there from the accuracy?
So the optimal value is fixed and is just like a reference value. And you can be off by, so blood pressure, let's say. So people consider optimal to be less than 120 over less than 80. People are in the 200s, people are in the so you'd be treated in the 200s, but there'll be lots of people in the 140s and the 150s, and there'll be a degree of kind of nihilism about that for some time. And my patients would be like, oh, I got into the fight with the parking attendant. Oh, I had a really bad phone. I mean, there's like countless excuses for why it is that one shouldn't start a medication, and this can go on for a long time. Yes.
I'm just wondering, like, how can you assess the risk, like, for instance, for blood pressure, as like noise linked to the measurements, like, you come once to the doctors, take the blood pressure, if it's high, you have a risk.
Yeah. So that's a great point. So the question is that many of the things that we're seeing as risk factors have inherent variability to them. Blood sugar is another great example of those things. So how are you, if you can have a single point estimate, that arises in the setting of a single clinic visit. How much should you trust that? So it's a couple of things related to that. So one of them is that people can be sent home with monitors, and they can have 24-hour monitors. In Europe, that's much more often done than here. And then, the thing is that they often, they'll say that, and then you go look at like 6 consecutive visits, and they all have something elevated. But it's true. So this is a noisy point estimate. And people have shown that averages tend to do better. But at the same time, if that's all you have, and the bias is interesting, because the bias comes from some degree of stress, but we have lots of stress in our life. I hopefully am not the most stressful part of my patient's life, and so I think that ultimately there are. And the problem with that is it's a good reason for someone to talk you out of them starting them on anything, and that's what ends up happening. And so this could be a really long period of time, and I think this is, okay, so this is the grim part, okay? So it turns out that once symptoms develop for something like heart failure, decline is fast. So 50% mortality in 5 years after somebody gets hospitalized for their first heart failure admission, and often the symptoms are just around that time. So unfortunately, these things tend to be these sort of irreversible changes that happen in the background, and largely you don't really have any symptoms until late in the game. So we have this problem where we have this huge stretch. We know that there's risk factors, but we have this huge stretch where nobody's doing anything about them, and then we have sort of things going downhill relatively quickly after that. And unfortunately, I would make a case that probably responsiveness is probably best at this phase over there. Expense is really all over there. So we really want to find, and this is what I consider to be missing in medicine. I'm going to come back to this again a little bit later on, but really we want to have these kind of, if you're going to do something in this asymptomatic phase, it better be cheap. You're not going to be getting MRIs every day or every year for people who have these, no symptoms. I mean, the system will bankrupt if you have that. So we need these kind of low-cost metrics that can tell us at an individual level, not just if we had 1,000 people like you, somebody would benefit, but really, and this is what my patients would say, is they would be so excited about their EKG or their echo being done every year, because they want to know, how does it look like compared to last year? They want some comparison at their level, not just some public health kind of report about so-and-so being, this being a benefit to 100 people like you. And so it should be both kind of low cost, should be reflective at something at an individual level, should be relatively specific to the disease process, expressive in some way, and should get better with therapy. I mean, I think that's one of the things that's pretty important, is if somebody does the things you ask them to do, hopefully that will look better. And then that will be motivating. And I think that's kind of how people get motivated, is that they get responses. So I would make a case that even simple things like an ultrasound, and I have one showed here, really does capture some of these things. And not all those things, but they have some of those things. So you have, for example, that in the setting of high blood pressure, the left ventricular mass starts to thicken. And this is a kind of a quantitative continuous measure. It just thickens over time. And the heart starts to change. The pumping function can get worse over time. The left atrium, which is this structure over here, this thin-walled structure, is amazing in the sense that it's almost this barometer for the pressure in the heart, and that that's a horrible reference. Okay, so but it tends to get kind of bigger and bigger in a very subtle way before any symptoms happen. So you have this, and this is just one view, right? So this is a simple view acquired from an ultrasound that captures some of these things at an individual level. So this gets to some of my thoughts around where we could imagine automated interpretation benefiting. So if you want to think about where you're less likely, so with these kind of very, very difficult kind of end stage or complex decisions where you have a super skilled person even collecting the data in the first place, they've gone through training, they're sort of super experienced, you have a very expensive piece of hardware used to collect the data, you have an expert interpreting it, this is done late in the disease course, you have to make really hard decisions. These are probably, and you don't want to mess it up, these are probably not good places to try to stick in a automated system in there. But what would be attractive would be to try to enable studies that are not even being done at all. So move to the primary care setting, use low-cost handheld. So there's even now companies that are starting to try to automate acquisition of the data by helping people collect it and guide them to collecting the right views. Early in the disease course, no real symptoms here. Decision support, just around whether you should start some meds or intensify them, low liability, low cost. So this is a place where we wanted to focus in terms of being able to introduce some kind of innovations in this space. Okay, so this comes back to this sort of slide of, I talked about where you could imagine some of these things being low-hanging fruit, but maybe those aren't the ones that we should be focusing on. We should instead be focusing on enabling more data at low cost getting more out of the data that we're collecting and helping people even acquire it in the first place. So that's one category of things, and that's the one I just highlighted in the previous slide. You can imagine something running in the background at a hospital system level and just checking to see whether there's anybody who was missed in some ways. And then triage, I'm going to talk about in the next slide. We'll come back to that. And then really, and this is again one of the reasons I got into this, we want to do something that elevates practice beyond just simply repeating what we already do. And so this kind of idea of quantitative tracking of intermediate states, subclasses of disease, which is actually the real reason I got into this space, is because I wanted to kind of increase scale of data to be able to do this. And this is kind of where you potentially would like to go. So the ECG example is an interesting one, because automated systems for ECG interpretation have been around for 40 or 50 years. And they really got going around the early 2000s when people realized that, so there's a structure, there's a pattern called an ST elevation. I'm not sure if you guys talked about that. This is a marker of complete stoppage of blood flow to the heart, so muscle starts to die. And in the early 2000s, there was a quality measure, kind of a quality kind of movement that said, as soon as anybody sees that, you should get to somebody doing something about it within an hour and a half or so. And so the problem was that the old days, and the old way to do this, and even this is around the time I was a resident, you would have to first call the cardiologist, wake them up, they would come, you would send them the image, they would look at it, then they would decide whether or not this was the pattern they were seeing, and then they would activate the lab, the cath lab, they would come in, and you were losing about an hour, hour and a half in this process. And so instead, they decided that automated systems could be used to be able to enable ambulance personnel or emergency room docs, so non-cardiologists, to be able to say, hey, look, this is what we think is going on, let's bring the team in. And so people would get mobilized, people would come to the hospital. Nobody would do anything in terms of starting the case until somebody confirmed it, but already the whole wheels were turning. And so you have this sort of triage system where you're making a decision. You're not finalizing the decision, but you're speeding things up. And so this is an example where you can imagine it's important to try to sort of offload this to something. So this is an example. And there's going to be false positives. And people will laugh and mock the emergency room doctors and mock the ambulance drivers and say, they don't know what they're doing. They don't have any experience. But ultimately, people were dying because they were waiting for the cardiologist to be available to read the ECG. So you got to think about those in terms of things, sort of places where there may be cost for delay. OK, so coming back to echoes. OK, so what is an echo study? Because this is probably not something that is typical. It's kind of a compilation of videos. And there are about 70 different videos typically in the studies that we do at the centers that we're at. And they're taken over multiple cycles and multiple different views. And often it takes somebody pretty skilled to acquire those views, and they take about 45 minutes to an hour to gather that data. Multiple different views, the sonographer is sort of changing the depth to zoom in on given structures. And so you can understand that there's already somebody who was already very experienced in this process, even collecting the data, which is a problem, because you need to take them out of the picture because they're expensive to be able to do those things. So we were doing at UCSF 12 to 15,000. Brigham was probably a little busier at 30 to 35,000. Medicare back in 2011 had 7 million of these performed, and there's probably hundreds of millions of these archived. So lots of data. So we published a paper last year trying to automate really all of the main processes around this. And part of the reason to do all is it doesn't help you to have one little bit automated, because at the end of the day, if you have to have a cardiologist doing everything else and a sonographer doing everything else, then what have you really saved by having one little step? So the goal here was to start from raw study coming straight off the machine and try to do everything. And so that involves sorting through all these different views, coming up with an empirical quality score with it, segmenting all sort of the 5 primary views that we use, directly detecting some diseases, and then computing sort of all the standard mass and volume types of measurements that come from this. So we wanted to do it all. And this was I think it wasn't strikingly original in the algorithms that were used, but at the same time, it was very bold for anybody in the community to try to take this on. And of course, engendered all the backlash you could imagine when you try to do something like this. I'm still hearing it, but there's excitement. And certainly on the industry side, there's really excitement in that this is feasible. I was running a biology lab back in 2016 or so, and then decided, so my cousin's husband is the dean of engineering at Penn, and I emailed him and said, "Do you know anyone at Berkeley? I live near there. I had a very long commute, so I was like closer to there. Is there anybody you know there?" So he's like, "Yeah, I know Rujna Bashti there. She used to be at Penn, and I know Alyosha Efros." And so he just emailed them and said, "Can you meet?" So, and actually Jitendra Malik also. And so I met some of them, and then I tried to find some people who were willing to work. So I actually spent a day a week there for about 2 years, just hanging out, writing code, and trying to get this kind of project off the ground. So we have a few different institutions. Jeff Tseng was a senior undergraduate at the time. He's at Illinois right now as a graduate student. It's interesting because it's hard to get grad student level people excited over stuff that's applications of existing algorithms. But they're happy to advise, and I think that's so. I ended up having to write a lot of the code myself, and undergraduates are of course excited to do these kind of things because it's better than homework, and I can pay. But I think ultimately it's interesting to try to find that sweet spot, and also find things that ultimately could be interesting from an algorithmic standpoint too. Which is, I'm trying to do more of that these days. Okay, so we aren't the first to even do something around classifying views. So somebody already had published something, but we wanted to be a little bit more nuanced than that, in that we wanted to be able to distinguish, for example, whether this structure, the left ventricle, is cut off, because we don't want to measure it if it's cut off, and we don't want to measure the atrium if it's completely cut off here. So we wanted to be able to have a classifier that is able to distinguish between some of those things. It's not an easy task, and and a lot of these labels were me riding the train in my very long commute from East Bay in California to UCSF, and so I did a lot of labeling, and I did a lot of segmentation too. So I applied a lot, and that's the other thing that's kind of interesting is that you often need, even to do the grunt work, you may need somebody fairly specialized to do it, which is okay. But yeah, so that ended up being me for a lot of this. So I traced a lot of these images. And then I got some other people to help out, but you're not going to get a computer science undergraduate to trace heart structures for you, nor are you going to get them excited about doing things. So we didn't end up having that much data, and I think we could probably get better than that. But we had this sort of 5 main views, and we implemented kind of a modified version of UNet algorithm. We sort of imposed a bit of a penalty to keep this sort of problem of, for example, a little stray ventricle being out there. We imposed a penalty to say, well, if that's too far away from the kind of the center, then we're going to sort of have the loss function kind of take that into account. That helped somewhat. But so that was sort of our approach to, and this is a pretty substantial deal to be able to do all these things that normally would be very tedious. And as a result, when we start to analyze things, we can segment every single frame of every single video. The typical Echo reader will take 2 frames and trace them. That's it. That's all you get. So we can do everything over every single cardiac cycle because there's amazing variability from beat to beat. And so, it's sort of silly to think that should be the gold standard, but that is the gold standard. So we had, thousands of echoes. So that's the other thing. So turns out that it's almost impossible to get access to echoes, so I wrote a keystroke encoder that sat at the front end and just mimicked me entering in studies and downloading them. So that was the only way I could get. So I had about 30,000 studies built up over a year, but there's no way to do bulk download. And so again, that was sort of, you got to do some grunt work to be willing to play in this space. So we had a fair number of studies we could use in terms of where we had measurements and decent values in terms of that. I mean, I think it's interesting in terms of thinking about how close one can get. And one of the things we found is that when there were big deviations, so these are Bland-Altman plots, almost always the manual ones were wrong. Oh, okay. So Bland-Altman plots are so people don't like using correlations in the medical field. So Bland and Altman published a paper in Lancet about 30 years ago complaining that correlations and correlation coefficients are ultimately not good metrics because you could have some substantial bias, and really you want to know if this is the gold standard, you need to get that value. So it really is just looking at differences between, let's say, the reference value and the, let's say, the automated value, and then plotting that against the mean of the two. So that's it. I did it as percentages here, but ultimately it's just that. So you're just kind of taking the mean of, let's say, the left ventricular volume. You have a sort of a mean of the automated versus the sort of the manually measured one, and then you compare what the difference is of one minus the other. And so you'll be on one side or the other. So ideally, you would just be sitting perfectly on this line, and then you're going to look and see whether or not you're sort of clustered on one side or the other. So that's just sort of the typical thing. People try to avoid correlation coefficients because they kind of consider them to be not really telling you whether or not, if there really is a gold standard and there truly is a value here, then you want to be near that value. And so that's the sort of that is the standard for looking at comparison of diagnostics. So we had about 8,000 things. So when the reviewers gave us a hard time for the space up here, and there are not that many studies up here, but ultimately there are some. And when we manually looked at a bunch of them, they were always the manual ones were just wrong. Either there was a typo or something like that. So that was reassuring. But we were sometimes very wrong. So sometimes, and you'd find that the places we'd be wrong would be these ridiculously complex congenital heart studies that we'd never given examples like that before. So it's a lesson to be learned, is that sometimes you're going to be really off in these sorts of approaches, and you have to kind of think a little bit. And what we ended up doing was having an iterative cycle where we would identify those and feed them back in and kind of keep on doing that. But that still needs to be improved upon. Okay, so function, again, there's a couple of measures of function, and there's a company that has something out there in this space, got FDA approved for having an automated ejection fraction, so I think we're better than their numbers overall, but yeah, I think that's just one of those things that you're sort of expected to be able to do. And then here's a problem that we ran into. So we're comparing to the status quo, which, like I said, is one person tracing two images and comparing them. That's it. So we're processing potentially 200, 300 different frames per study, and competing sort of medians, smoothing across. We're doing a whole lot more than that. So what do we do about that in terms of the gold standard? And if you just take inter-observer variability, you're going to have up to like 8 to 9% in an absolute compared to 60% of the reference. So that's horrible. So what are you supposed to do? And I think, so one thing people do is they take multiple readers and ask them to do that. But this is like, are you going to get a bunch of cardiologists to do like 1,000 studies for you? It's very hard to imagine somebody doing that. You could compare it to another modality. So we haven't done this yet, but you could, for example, compare it to MRI and say whether or not you're sort of more consistent with another modality. And then this is sort of indirect, but you can go to like outcomes in a trial and see whether or not you do a better job. So there are things you can do. One of the things we decided to do is look for kind of correlations of structures within a study itself, and say, well, the mass, so we know that, for example, thickened hearts lead to larger increases of pressure and left atrial enlargement. So we can look for correlations between those things and see whether we do a better job. I would say for the most part we're about on par with everything that's there. So I don't think we're any better. Sometimes we're better, sometimes we're worse. And I think for the most part this was sort of another way to try to get at this, because we were stuck with this. I mean, how do you work with a gold standard that ultimately I don't think anybody really trusts as a gold standard? And this is a problem that just kind of has to keep on coming up. This is just an example of where you could sort of facilitate this sort of idea of low-cost serial imaging at point of care. So these are patients who are getting chemotherapy, and so Herceptin, it's like Inception, is a EGFR inhibitor that causes cardiotoxicity, and so people are getting screening echoes. So you can imagine if you make it easier to acquire and interpret that, all you want to care about is the function and the size, so you can imagine automating that. So we just did this as sort of proof of concept that you could imagine doing something like this. And for the last thing I want to talk about, the last thing in this space is that you could also imagine directly detecting disease. And so you have to say, well, why is that even worthwhile? Yes?
I was curious, I guess it's going back a second, but if you thought about blended models between like human ground truth and maybe a biological ground truth, to say that in a crude way, so sort of like thinking about sort of a consensus among cardiologists versus sort of like what you would maybe get from an MRI or something, or maybe not necessarily an MRI, but what you were saying sort of based on the underlying biology, or if those two things are generally kept.
Yeah, I mean, I think everything these are early days for a lot of this, and I think anytime you make anything more complicated, then the readers will give you a hard time. But you could imagine that, and especially you may want to tune things to be able to be closer to something like that. So yeah, I think unfortunately people are pretty conservative in terms of how they interpret, but it does make some sense that there's probably something that, ideally you want to be able to have something that is useful, and useful may not be exactly the same thing as mimicking what humans are doing. So no, I think it's a good idea, and I think that this next wave is going to be thinking a little bit more about that in terms of like how do we improve on what's going on over there rather than simply dragging it back to that. Okay, so So there are multiple rare diseases. I used to have a clinic that would focus on these, and they tend to get missed at centers that don't see them that often. So one place you could imagine is you could focus on trying to pick those up. And you could imagine this could be just surveillance running in the background. It doesn't have to be kind of real-time identification. So there's a few diseases where it's very reasonable to do these things where it's sort of very obvious. So this is a disease called hypertrophic cardiomyopathy. I used to see in my clinic. So abnormally thickened hearts, leading cause of sudden death in young athletes. So Reggie Lewis, Hank Gath. I mean, there's a bunch of people who've sort of died suddenly from this condition. Unstable heart rhythms, sudden death, heart failure. It runs in families. And there are things you can do if you identified it. And so it's actually a fairly easy task in the sense that it tends to be quite obvious. So we built a classification model around this. And we tried to understand what it was doing. In part, and so we tried to do some of these kind of attention or saliency type things, and they were very unsatisfying, in part because I think there's so many different features across the whole image, so you're just getting this blob, but I think maybe we just weren't implementing it correctly. I'm not really sure. But you were getting, because there's, the left atrium get bigger, the heart gets thicker, there's so many changes across the image. It was sort of unsatisfying in terms of that. So we did something simple and just took the output of the probabilities and compared it to some simple things that we actually know about these things and found that there was some degree of correlation. But I would like to make that a little bit better. Cardiac amyloid, a very popular disease for which there are now therapies. And so pharma is very interested in identifying these people, and they really get missed at a pretty high rate. So we built another model for this. Usually we had about 250 or 300 cases for each of these things, and maybe a few thousand controls. And then this one's a little interesting in that this is mitral valve prolapse. So this is what a prolapsing valve looks like. So if you imagine the plane of the valve here, it buckles back. So it does this. And that's abnormal. And this is a normal valve. So you notice it doesn't buckle back in. So it's a little interesting in that there's really only one part of the cardiac cycle that would really highlight this abnormality. At least that's the way that, so the way that it's read clinically is people kind of wait for this one part of the cardiac cycle where it's buckled back. They draw an imaginary line across and they measure what the displacement is there. And so we built a reasonable model focusing. So we phased these images and picked the part of the cardiac cycle that was relevant, all in an automated way, and built a model around that. And pretty good in terms of being able to do that, in terms of being able to detect that. Yes?
And so is this model on images at a certain time, or like, can you just go back, because obviously you weren't doing it on videos, right?
Well, so we would take the whole video, we were segmenting it, we were phasing it, figuring out what the part of the, when was the end systole in that, and then using those as using a stack of those to be able to classify.
And so how would you know the time point?
Well, that's what I'm saying. So we were using the variation in the volumes.
Segmentation would allow you to know the time.
Yeah, exactly. Because so a typical echo will have an ECG to use to gate, but the handhelds don't. So we want to move away from the things that involve the fanciness and all the bells and whistles. We're trying to use the image alone to be able to tell the cardiac cycle. So that's how we did it. Yes, Steve.
Since you mentioned handhelds, would the ultrasounds from handhelds look a bit different from these? Or do you think
they look pretty similar? I mean, we got some now, and they look pretty similar in terms of the quality of the images, and you can acquire the very same view. So I think we haven't shown that we can do it off those, in part because there just isn't enough training data. But they look pretty nice. And I know, at UCSF and at Brigham, all the fellows are using it. It looks pretty much the same in terms of the transducers are sort of similar. And image quality is very good. Resolution is very good. Frame rate probably doesn't get up as high necessarily. But for the most part, I don't think it's that different. So that is kind of the next space. Yes?
Could you comment on, so you mentioned how each of these three examples could be used within a surveillance algorithm.
Yeah.
Could you comment on the where along this true positive, false positive trade-off you would actually be realistic to use?
Yeah, it's a good point. I think it would vary for every single one of those, and you really want to have some kind of costs on what the. So I would typically err on the side of higher sensitivity and dump it on the cardiologist to be able to so I would work in but I think you have to sort of pick some, if you, let's say you're a product manager.
Just choose one of these three and maybe pick
okay.
to walk us through it.
Yeah. So this is a pretty rare disease. So your priors are pretty low in terms of these individuals. And so I think you probably would want to err somewhere along this sort of this area here. And so just working on so you probably will still be a relatively high rate of false positives, even in that space. But if, I would argue that it would take the treating cardiologist potentially just a few minutes to look at that study again. And if you picked up one of those patients, that would be a big win out of, so I think the cost probably wouldn't be that high, and you just have to make the case. And I think so therapy for amyloid, for example, with these, it's a nice sort of sharp upstroke there. There's new drugs out there that are sort of begging for patients, and they're having a real hard time identifying them. So you could imagine, again, it's sort of a calculus based on what the benefits would be for that identification and what burden you're placing on the individuals to have to overread something. And you could probably tune that depending on sort of what the disease is and who you're sort of pitching it to. But if, you're right, you're going to crush people if like 1 in 100 ends up being a true positive, then you're not going to win many fans. Yes?
Could you comment on whether, for example, for amyloidosis, the ones that you're able to predict very well, so for example, at that cut point you disclosed, what distinguishes the ones that you're able to find well?
That's a good, so that's a good point. And I don't know in the sense that I haven't looked that closely, but I'm going to guess they're very thick. And very obvious in that sort of sense. And so we have a ECG model that may pick this up early. What you want is something that picks it up when it's treatable, not having something that's sort of ridiculously exaggerated. So you may need multiple modalities, some of which are more sensitive than others, that can catch earlier stage disease to be able to do that. So there are interesting things about this disease in particular. So cataracts sometimes happen before so ideally the way you would do this is, and I'm actually kind of consulting around something like this. You ideally want a mixture of an electronic health record, sort of something from other findings, neuro findings, eye findings, plus maybe something cardiac, and have something that ideally catches the disease in the ideal most treated state. And maybe echo is not the best one, and I think that we'll come back to that at the end. We have a little bit of time. Okay. So UCSF is filing. I don't know. I don't think this is actually patentable, but they are filing for a patent. I'm just filling the paperwork out today in terms of the. I don't know, but my code is all freely available anyway. So. For academic nonprofit use. And we're just trying to make it better. I think ultimately my view as an academic here is to try to show what's possible. And then, if you want to get a commercial product, then you need people to weigh in on the industry side and make something pretty and make it usable and all that. But I think ultimately I'm sort of trying to just show, hey, if we can do this in a scalable way and find out something new, then you guys can catch up and do something that ultimately can be deployed. And what's interesting is I have a collaborator in New Zealand. They're resource poor, so they have a huge backlog of patients. They don't have enough sonographers and they don't have enough cardiologists. So they're trying to implement this super sort of ultra quick 5-minute study and then have automation. And so they want our accuracy to be a little bit better, but I think they're ready to roll out if we're able to get something that sort of has probably more training data. Yes. Are you from New Zealand?
No. I think he started talking about it, the trade-off between accuracy and... So in academia, I get the sense that we're always chasing perfect accuracy.
Yeah.
But as you said, we're not going to get rid of cardiologists in the diagnosis. So I have a philosophical question of, are we chasing the wrong thing? Should we chase perfect accuracy?
Yeah, so the question is around what should our goals be, and I think so should we be just chasing after a level of accuracy that may be either very, very difficult to attain, and especially if there's never a scenario where there will be no clinician involved, should we instead be thinking about something that gets good enough to that next step? And I think that's a really good point, and the field, and what's interesting is, and also it's interesting from the industry side, is the field starts with the mimicking mode because it's much harder to change practice. It's much easier to just pop something in and say, hey, I know you have to make these measurements. Let me make them for you. Then you can look at them and see if you agree. So that's what ECGs do, right? So nobody these days is measuring the QRS width, and nobody does that. I mean, that's just not done. If you've got a number that's absurd, you'll change it. But for the most part, you're like, it's close enough. But you almost have to start with that. To do something that's sort of transformative is very hard to do. So I think something that involves, and I talked to David about this, is sort of like the man-machine interface is fascinating to think about how do we together come up with something better, but it's just much harder to get that adopted because it requires buy-in in a way that's different than just you do my work for me, but more that we come together to do something better. And I think that's going to be interesting as to how to chip away at that problem. Okay. Okay, so a couple of musings, and I'm going to talk a little bit about One Brave Idea if we have time, or I can take, actually I'll stop and take questions instead, because it's a little bit of a biology venture. Okay, so I do think that we should really look, when people give me a hard time around echo, and I'm like, well, ECG's been around for a long time and there's automation there, so let's think about how it's used there, and then see whether or not, it's not as outlandish as people think. So I think a lot of these routine measurements are just going to be done in an automated way. And then you can, we already in our software, you can put out a little picture or overlay the segmentation on the original image and say how good it looks. So that's easy. So you can do that. And then this kind of idea of point-of-care automated diagnoses can make some sense around some emergency type situations. So maybe you need a quick check of function. Maybe you want to know if they have a lot of fluid around the heart and you don't necessarily want to wait. So those will be the places where there may be some kind of innovations around just getting something done quickly, and then you always have somebody checking in the background later on, a little like the heart attack thing I showed you. And I think this problem in echo is there. And so if you need skilled people to be able to acquire the data in the first place, you're stuck, because they can read an echo really well. A really good sonographer can read the whole study for you. So if you already have that person involved in the pipeline, then it's really hard to sort of introduce a big advance. So you need to figure out how to take a primary care doc off the street, put a machine in their hand, and let them get the image, and then automate all the interpretation for them. And so until you can kind of task shift into that space, you're stuck with having still too high a level of skill. So there are these companies that are in this space now. There's a few that are trying to. It's easy to imagine if you can train a neural network to classify a view, you can get it to recognize. This kind of gets to this idea of registration a little bit. You can recognize if you're off by 10 degrees or if you need a translation. You could just train a model to be able to do that. So I think that's already happening right now. So it's a question as to whether that will get adopted or not. But I think that ultimately, if you want to sort of get shifting towards sort of less skilled personnel, you need to do something in that space. Okay, so this is where it gets a little bit harder, is to think about how to make stuff and elevate medicine beyond what we're doing. And this gets back to this problem I mentioned, is that at the end of the day, you can't find new uses for echo unless the data is already there for you to be able to show that there's more value than there currently is. So sort of this chicken and egg thing. So in some sense, what I'm trying to hope to introduce is some way that we can get much bigger data sets, and they don't have to be 100 video data sets. They can be like 3 video data sets. But we want to be able to sort of figure out how to enable more and more of these studies. So then you can sort of imagine learning many more complicated things. You want to track people over time. You want to look at treatment responses. So you got to look at where the money is already and see who could do this. So pharma companies are interested because they have these phase 2 trials. They may only have 3 months or 6 months to show some benefit for a drug. And they're really interested in seeing whether there's differences after a month, 2 months, 3 months, 4 months. So that may be a place where you get, and they're being frugal, but they have money. So you could imagine if you could introduce sort of this pipeline in there and just have handheld, simple, quick to acquire, far more frequency, and you show a treatment response, then that's kind of transformative then, because then you could imagine that can get rolled out in practice after that. So you need somebody to bankroll this to start with, and then you could imagine once you have a use case, then you could imagine it getting much more. And this kind of idea of surveillance, you could imagine that would be very doable, is that you could just have something kind of taking, the problem is you can't even get the data in the archives anyways, but let's say you could get that. You could just have this system looking for amyloid, looking for whatever, and that would be a win too, is to be able to imagine doing something like that. It's not putting any pressure on the clinical workflow. It's not making anybody look bad. I think ultimately it's trying to just figure out if somebody may be looking bad, I guess, if they missed something. But yeah, I think it is just trying to sort of identify individuals. And so this is an area I think that's hard. And so this kind of idea, and this is where I started a little bit around this kind of idea of disease subclassification and risk models. And so that's more sophisticated than anything we're doing. I think we're pretty crude at this kind of stuff. But one of the challenges is people just aren't interested in new categories or new risk models if they don't have some way that they can change practice. and that becomes more difficult because then you need to not only introduce the model, you need to show how incorporating that model in some way is able to either identify people who respond to therapy. I mean, it always comes down to therapies at the end of the day. So can you tell me some subclass of people who will do better on this drug? And which means that you have to have trial data that has all those people with all that data. And unfortunately, because echoes are so expensive, and our places like the Brigham charge like $3,000 per echo, then you only have like 100 people who have an echo in a trial, or 300 people in an echo. You have a 5,000 person trial, and 5% of them have an echo. So you need to change the way that gets done, because you're massively sort of underpowered to be able to detect anything that's sort of a subgroup within that kind of work. So yeah, unfortunately, the research pace of things outpaces the change in practice in terms of the space until we're able to sort of enable more data collection. So I can stop there. I was going to talk about blood cells and slides, but
Take some questions and see if
yeah,
there's time remaining.
yeah. Okay, why don't we do that? Yes.
When CT reconstruction started, I remember seeing some papers where people said, well, we know roughly what the anatomy should look like, and so we can fill in missing details. Like in those days, the slices were rather far apart, and so they would hallucinate what the structure looked like.
Yeah.
And of course, that has the benefit of giving you a better model, but it also has the risk that it's hallucinated data. Have you guys tried doing that with some of the?
Yeah, that's a great point. So the question was, so cardiac imaging has a very long history, and so there was a period of time where there's these kind of active modelers around morphologies of the heart. And so people have these sort of models around what the heart should look like from many, many, many studies. And they were using that back at the time when you had these relatively coarse multi-slice scanners for a CT. They would reconstruct the 3D image of the heart based on sort of some pre-existing geometric model for what the heart should look like. And there's, of course, some benefits to that, but some risk in the sense that somebody may be very different in the space that's missing, and you may be. And so the question is whether those kind of priors can be introduced in some way. And it hasn't been straightforward as to how to do that. But I mean, that's whenever you look at these sort of ridiculously poor segmentations, you're like, this is idiotic. We should be able to introduce some of that. And I've seen people, for example, put an autoencoder. I mean, that's not exactly getting at it, but it's actually getting at some of these kind of coarser features. But no, I think in terms of using kind of some degree of geometric priors, I think I may have seen some literature in that space. We haven't tried anything there. We don't have any data to do that, unfortunately. And I suspect, I just don't know how difficult that is.
I mean, you mentioned that you don't want to see a small additional atrium at a distance. So that's in a way building in knowledge.
Yeah, no, I remember when I was starting in this space, I was like, this is idiotic. Why can't we do this? Why don't we have some way of doing that? We couldn't find at that time any architectures that were straightforward to be able to do that, but I'm sure there is something in that space. And we didn't also have the data for those priors ourselves. I mean, there's a long history of these kind of de novo heart modelers that exist out there from Oxford and the New Zealand group, for that matter, who've been doing some of this kind of multi-scale modeling. I'm sure there's. I mean, it'll be interesting to see whether or not there's anybody who kind of pushes forward in that space, or is it just more data? I think that's always that tension.
Can I ask about ultrasounds?
Yeah.
You didn't show us ultrasounds, right?
Yeah, I did.
Oh, you did?
Yeah, the echo's an ultrasound.
Oh, but
Yeah.
that's a really expensive ultrasound, right? Like there are cheaper ultrasounds that you could imagine that you constantly do, right?
Yeah. So there's a company that just came out with a $2,000 handheld ultrasound with a subscription model, and yeah. So I think that so Philips has a handheld device around the $8,000 mark or so. $2,000 is getting quite cheap. So that's, I think, the space for handheld devices.
We're talking about like resource poor countries.
Yeah.
Like in a developing country where maybe they have very few doctors per like population kind of thing. What kind of imaging might be useful that we could then apply computer vision algorithms to do?
I think ultrasound is that sweet spot. It has versatility. And its cost is about where, and I'm sure those companies rent it out for much lower cost in those kinds of places too. So that, we're putting together, or I put together, actually it may not have been funded, I'm not sure, but looking at sub-Saharan Africa and collaborating with one of the Brigham doctors who travels out to sub-Saharan Africa and looking to try to build some of these automated detection type of things in that space. So no, I think there's definite kind of interest in that, and there may be a much bigger win there. Than kind of the sort of stuff I'm proposing. But yeah, no, I think that's a very good point. And that would be, it's portable, you can have a phone-based sort of thing, so it's very attractive from that standpoint.
Take us 5 minutes to finish.
All right, I feel like I'm changing the topic substantially, but not totally. Okay, so this is that slide I showed. And I pitched it in a way to try to motivate you to think about ultrasound, but I'm not sure ultrasound really achieves all these things. In the sense, I wouldn't call it the greatest biological tool to get at kind of underlying disease pathways. Some of these things may be late, like David said, or maybe not so reversible. So we've been given at this One Brave Idea thing $85 million now to make some dent in a specific disease, so coronary artery disease, or coronary heart disease. It's that kind of arrogant tech thing where you just dump a lot of money somewhere and think you're going to solve all problems. And I'm happy to take it, but I think that there are some problems. And so this is what I wanted to do. So I wanted to do this for probably the last 5-6 years before I even started here. And this has kind of motivated me in part for quite a while. And so here's our problems. Okay, so we're studying heart disease. So coronary artery disease, or coronary heart disease, is the arteries in the heart. You can't get at those. So you can't do any biology. You can't do the stuff that cancer people do. You can't biopsy that. You can't do anything there. So you're stuck with the thing that you want to get at is inaccessible. I talked about how a lot of the imaging is expensive, but all those other omics stuff is really expensive too. So that's going to be not so possible to imagine. You're not going to be able to do serial $1,000 proteomics on people either. That's not happening anytime soon. And then everything I talked about, we're woefully inadequate in terms of sample size, especially if we want to kind of characterize underlying complex biological processes. So we expect we're going to need kind of high-dimensional data, and we're going to need huge sample size. There's Vladimir Vacnik over there. And then here's another problem, okay? So this stuff takes time. These diseases take time. So if I introduce a new assay right now, how am I going to show that any of this is going to be beneficial? Because this disease develops over 10 to 20 years. So I'm not going to talk about the solution to that. Well, a little bit. Okay, so one of the issues with a lot of the data that's out there is it's not particularly expressive. It's a lot of just the same clinical stuff. The same imaging stuff. So all these big studies, these billion-dollar big studies, ultimately just have echoes and MRIs and maybe a little bit of genetics, but they really don't have stuff that is this kind of low-cost, expressive biological stuff that we ideally want to be able to do. So this is really expensive. I mean, it makes $85 million look like a joke. And it's not all that rich in terms of complexity. So we wanted to do something different. And so this is the crazy thing. We're focusing on circulating cells. And so this is kind of a compromise, and there's a reasonably good case to be made for their involvement. So there's lots of data to suggest that these are causal mediators of coronary artery disease or coronary heart disease. So you can find them in the plaques. There are patients who have autoimmune diseases certainly have accelerated forms of atherosclerosis. There are drugs. There's a drug called canakinumab that inhibits IL-1 beta secretion from macrophages, and this has mortality benefit in coronary artery disease. There are mutations in the white blood cell population themselves that are associated with early heart attacks. So there's a lot there, and this has been going actually, and there's plenty of mouse models that show that if you make mutations only in the white blood cell compartment, that you will completely change the disease course itself. So there's a good kind of amount of data out there to suggest that there is an informative kind of cell type there. It's accessible. There's lots of predictive models already there that could be done with some of this, and they express many of the genes that are involved. And there's sort of a window on many of these biological processes. So we're focusing on computer vision approaches to this data. So we decided if we can't do the omics stuff because it costs too much, we're going to take slides and have tens of thousands of cells per individual, and then we can introduce fluorescent dyes that can focus on lots of different organelles, and then we can potentially expand the phenotypic space by adding all kinds of perturbations that can kind of be able to unmask attributes of people that may not even be relatively there at baseline. And I think I've been empowered by the kind of the computer vision experience with the Echo stuff, and I'm like, hey, I can do this. I can train these models. So we're in a position now where we can, this stuff costs a few dollars per person. It's cheap. And you can just keep on expanding phenotypic space. You can bring in drugs. You can bring in whatever you want here, and you're still in this sort of dollars type range. And so we just piggyback and we just hover around. So with just a couple of research assistants, we're hovering around clinics, and we can do 1,000 patients a month, so tens of thousands of patients a year. So we can get into kind of deep learning sample size here, so we want these sort of primary assays to be low-cost, reproducible, expressive, ideally responsive to therapy. So that's kind of this space here. And there's lots of stuff that we have all the medical record data on all these people, and we can selectively do somatic sequencing. We can do genome associations. We have all the ECG data. We have selective positron emission data. So it's lots of additional and we want to be able to walk our cheap assay towards those things that are sort of more expensive, but for which there's much more historical data. So that's what I do with my life these days, and the time problem has been solved because we found a collaborator at MGH who has 3.5 million of these records in terms of cell counting and cytometer data going back for about 3 years. So we should be able to get some decent events in that time. I need to build a document classification model for 3.5 million records to decide whether they have coronary heart disease, but sounds like that's doable. We're sort of fearless in this space. And then they also have 13 million images, so hundreds of thousands of people with worth of slides. So we can at the very least get decent weights for transfer learning from some of this data. And we're doing this for acute heart attack patients. So this is kind of what I'm doing ultimately. And so it's this sort of bridge between existing imaging, existing conventional kind of medical data, and this kind of low-cost, expressive, serial type of stuff that ultimately hoping to expand phenotypic space and keep the cost down. I think all my sort of lessons from working with expensive imaging data sort of motivated me to build something around this space. So this is my baby right now, and so lots of things for people to be involved in if they want to. And these are some of the funding sources. All right, thank you.